right. Hello. I'm just so excited that I can see over this podium. Usually it's too tall for me. Um, I'm Jessica Yee, and I'm here today to talk to you about the top 5 things that every urologist should know about female sexual dysfunction. I'm so excited. I remember the moment when I walked in 8 years ago at SMSNA at AUA, and I saw Dr. Irwin Goldstein give a lecture, and I learned for the first time about the female prostate and that there's urologists interested in female sexual health, and I'm just so honored to be here today, and thank you so much to SMSNA for supporting women's sexual health. And thank you to Helen and Tammy for really setting the stage for me. I told them, you guys gave us some foreplay. Hopefully we'll reach the climax a little bit easier. So, no disclosures. I want to start with a case study. So we have a 56-year-old man with no past medical history presenting with low libido, inability to achieve orgasm, penile pain. His testosterone is found to be 120, no estradiol detected, and he's told when he's going to the doctor that men his age have low testosterone, that this is his new normal, testosterone therapy is dangerous, and he should try therapy for his low libido and orgasm. And for his penile pain, he should use moisturizers and lotion. So if this sounds ridiculous to you, it is. It should be, and this is unfortunately the reality for most women who go to their doctors about their sexual health concerns. So female sexual dysfunction affects nearly 50% of women. The disorders of desire, arousal, and pain are urological in nature. They're hormonal, vascular, anatomical, but it continues to remain underdiagnosed, underdiscussed, and undertreated. For a long time, female sexual dysfunction was thought to be mental and psychological, right? Just like erectile dysfunction. But we know now that there's so much urological pathophysiology. And women are desperate to get treatment for these issues. And we're also getting a lot of feedback from our medical students, our fellows, all our trainees that they really want to learn how to treat women's sexual health. So it's really up to us to make this part of our urological care. So my goal today is not to make you an expert in the next 15 minutes, but just to show you that women's sexual health is rooted in anatomy and physiology, and that we really need a urologist to be in this game to treat these patients. So I hope I show you something here that will intrigue you to learn more and inspire you to go on to treat patients as well. So first, talking about testosterone. Testosterone plays a critical role in women's sexual health. It impacts the libido, orgasm, arousal, and mood. I first learned this in fellowship, but women primarily for most of their life have more testosterone than estrogen in their bodies. They produce 100 to 400 micrograms per day of testosterone, primarily from the ovaries and the adrenal gland. The levels, however, start declining in the 30s. So this study out of Australia in 2019 looked at women aged 18 to 39 and found that all androgen levels were significantly lower in those aged 35 to 39 than those aged 18 to 25. And for testosterone specifically, about 25% lower. We actually do have a lot of data looking at testosterone therapy in women. So this meta-analysis published in 2019 looked at 36 randomized controlled trials and showed significant improvements in sexual dysfunction with non-oral testosterone treatments. So these improvements were increase in sexual satisfactory events, increase in sexual desire, pleasure, orgasm, arousal. However, this data was primarily for postmenopausal women. We have guidelines, a couple of guidelines looking at testosterone in women. One is the Global Consensus Position Statement published in 2019. This was endorsed by the Menopause Society, the Endocrine Society of Australia, as well as ISHRS and IMS. The testosterone treatment is indicated for hypoactive sexual desire disorder or low libido, and therapy should be aimed for premenopausal physiological testosterone levels. ACOG, the American Academy of Gynecology, also put out a consensus statement in 2023 stating that short-term transdermal testosterone should be considered for postmenopausal women with sexual interest and arousal disorder. We do have some limited data on testosterone therapy in premenopausal women, showing that it can improve libido and mood in patients with low desire. It's especially important for a woman with premature ovarian insufficiency, so premature menopause, and surgical menopause, and they often benefit from testosterone therapy as well. If you remember just a few slides ago, I told you that testosterone starts to decline in the late 30s, right? So that's well before menopause in the early 50s. And so the takeaway here is that we really should also be checking testosterone in younger women with low libido, low desire, and other sexual dysfunctions. And to wait for menopause is really to undertreat these patients. So what about the safety of testosterone in women? We do have good long-term data actually looking at testosterone and cancer risk and cardiovascular risk, showing that there's no significant increase in breast cancer or cardiovascular risk in testosterone users, including premenopausal women. And the global consensus in 2019 and the ACOG guidelines in 2023 also emphasize that there is safety with physiological dosing. So avoiding testosterone out of fear is denying care based on outdated data, just like we were doing for testosterone-related prostate cancer, still continuing that currently, unfortunately, with testosterone in women. So how do we prescribe testosterone? We have two options. We can use either an FDA-approved male dosage at a female dosage level, or using compounding pharmacy for female-appropriate dosage levels. And generally around 2 to 5 milligrams per day is appropriate, so our testosterone levels in women are about 1/10 that of men, so we should be treating them with about 1/10 the dosage of men. Now on to estrogen. So the barrier to estrogen treatment is not the estrogen therapy itself, right? The estrogen prescription. So when I treat patients for estrogen hormone replacement therapy, it's very simple. I use an estrogen patch that's changed out twice a week and a progesterone pill that's taken nightly for those with an intact uterus. So it's can be very simple. The barrier to estrogen therapy is the fear of breast cancer. And so this mostly comes from the WHI study that was published in 2002, which really overstated risks associated with estrogen therapy. And so this is a very simplified kind of data about this, but essentially, there was a lot of misinformation around estrogen and breast cancer, and when you really dig into the data, there is actually no increased risk of breast cancer related to estrogen therapy. So we do not have any definitive data associating estrogen use with breast cancer. Vaginal estrogen, even less risk, right? If we're talking about systemic hormonal therapy versus vaginal estrogen. Vaginal estrogen is a much lower dosage that is just used essentially for GSM, it improves dysuria, urgency, stress incontinence, urgent incontinence, and recurrent UTIs. It's effective and it's safe, and it doesn't increase our systemic estrogen levels significantly. There is still, unfortunately, currently a black box warning on vaginal estrogen. However, this isn't based on evidence, right? So it was extrapolated from systemic hormone therapy, that there was a lot of misinformation about that, and the FDA took that misinformation and applied that blanket to all estrogen products. Multiple professional societies agree that it should be removed because estrogen is among the safest and most effective treatments for GSM. So how do I prescribe estrogen therapy, vaginal estrogen therapy? The two main forms that I prefer is either using a vaginal estrogen ring. This can be placed for 3 months at a time, very simple for someone older who doesn't want to have to do something every day, place 3 months at a time. They can change it out themselves, or they can come to clinic and we can change it out for them. A vaginal estrogen cream is also very easy to use. I tend to like to prescribe it on a daily basis. Typically, when you get it from the pharmacy, they say it's a 2 to 3 day a week dosing, but I find that patients often forget when they're given a 2 to 3 day a week dosing. So if you use less on a daily basis, maybe half a gram on a daily basis, patients tend to remember that better, and it still gives them a sufficient amount of vaginal estrogen without raising their systemic hormone levels. So that is very quick about testosterone and estrogen. If you're interested in learning more, Sue talked about ISWISH. So ISWISH has an advanced hormones course. The first webinar for this was last night, so it's fantastic. You can still go up and sign up online. Please take a look at this if you want to learn about hormone prescriptions. Next, I want to talk about the vestibule. So the vestibule is a urological organ. So, I don't blame anyone for not knowing about the vestibule if you don't know about it yet. I didn't learn about it essentially until fellowship. But the vestibule on this photo, courtesy of Dr. Irwin Goldstein, is the tissue that's encompassed by Hart's line. So there's a transition here from the skin of the vulva to the mucosa of the vestibule. And in this is contained the urethral meatus. So the vestibule is innervated by pain and sensory receptors, by sympathetic and parasympathetic fibers from the pudendal nerve and the inferior hypogastric nerve. And so this is similar to the bladder and the urethra, making this a urological organ. If you remember back to embryology, the vestibule is what tubularizes to form the male urethra. It has both estrogen and androgen receptors and is sensitive to both estrogen and androgens. Hormone deficiency can cause vestibulodynia and cause pelvic floor dysfunctions, and hormonal treatments can improve these symptoms. Clinically, vestibulodynia is also really associated with voiding dysfunctions, urgency, overactive bladder, and bladder symptoms. So our understanding of the vestibule and our ability to treat these vestibular conditions is really critical to our ability to treat not only female urological conditions as well as female sexual dysfunctions. Briefly about cardiovascular health. There's growing evidence showing that FSD may be associated with underlying cardiovascular risk factors. Clitoral vascular resistance, as measured by clitoral pulsatile index using color Doppler ultrasound, is associated with various risk factors such as obesity, insulin resistance, and metabolic syndrome. There's been a lot of interest in clitoral ultrasound to evaluate for FSD as well as to evaluate for this potential cardiovascular risk. This is a webinar that was put on by ISWISH a few months ago, led by Jandra Mueller and Kimberly Murdow. It's online, still available to be viewed free of charge. If you want something in person, the ESSM is hosting a female ultrasound school later this year in November in Budapest, Hungary. So potentially very exciting course here that you can go take to learn about clitoral ultrasound. Finally, advanced surgical techniques. So I think a lot of people have this misconception that female sexual dysfunctions can be treated by nurse practitioners, by internists, by family doctors, but a lot of these issues are really urological and really require surgery to advance their care. So I think it's really important for urologists to really be at the forefront of the care of women's sexual health for these reasons. So one of the tried and true methods for treatment of vulvodynia, specifically vestibulodynia, which is if you have neuroproliferative vestibulodynia, is a complete vestibulectomy. These photos are from Dr. Irwin Goldstein. So this is the vestibulectomy that we used to do, and we've made a lot of improvements to this technique over the last few years. Dr. Alyssa Yee has done some really incredible innovative work looking at the 12 o'clock vestibule, doing the buccal mucosa graft actually to close the excision of the 12 o'clock vestibule, as well as only taking a thin layer of the mucosa, maybe 1 or 2 millimeters of the mucosa of the vestibule, because that's where all the nerve endings are, all the nerve fibers that are causing pain. And so the post-op pictures show a vulva, a vagina that really is inseparable. Like you can't tell the difference between pre and post-op after a vestibulectomy. Here's some pictures of her buccal mucosa graft. This is pictures of clitoral lysis of adhesions, another surgical procedure that's done for clitoral adhesions causing pain, discomfort, keratin pearls underneath the clitoral hood. We're revising and finishing up a video of clitoral lysis of adhesions that's coming out soon in the VJSM, so be on the lookout for that. Another really interesting procedure is pudendal neuromodulation. This is really pioneered by Dr. Ken Peters. He's actually, I think, teaching a course on another floor here. So that's where I'm going to head after this to learn from him. But really interesting techniques here to help with pudendal neuralgia and pelvic pain. So again, This is just a very quick overview. If you're interested, and hopefully I've inspired some of you to learn more, please come to the ISWISH Fall course, as well as the annual meeting. We dive into these topics. There's so much to learn about this, and it is primarily internists and gynecologists and NPs, but we do also have a lot of urologists in the group, and I think it's so important for urologists to be at the forefront of this research, of this care, because it's only then that we can really advance the care for these women. Thank you.